The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with Inside JACC and about to discuss a very interesting paper that we're about to publish that deals with the preventive therapy in patients who develop left ventricular dysfunction after chemotherapy. And here to discuss that with me is the senior author, Dr. Ron Witteles, who's assistant professor of medicine at Stanford. So, Ron, tell us a little bit about your study.
Sure. We're looking in the larger context of this issue of cardiotoxicity in cancer therapies, which has really grown over the last decade. What we wanted to look at was not the incidence of cardiotoxicity, which has been well characterized in other studies, but rather to say what happens when a patient develops a treatment-emergent drop in their left ventricular ejection fraction. What we wanted to see specifically is with the two most common agents which cause cardiotoxicity, anthracyclines and trastuzumab. If patients had a drop in systolic function, did they get guideline-indicated therapy with beta blockers and ACE inhibitors or angiotensin receptor blockers, as well as did they get referred for cardiology consultation?
So you had a fair number of patients that you dealt with. Did these patients, in fact, get appropriate therapy when their EF was reduced?
Well, it depended entirely on if they had symptomatic drops in left ventricular systolic function. In that case, the vast majority of patients did get referred to cardiologists, did get started on beta blockers, did get started on ACE inhibitors or angiotensin receptor blockers. However, the larger cohort of patients who had asymptomatic drops in left ventricular systolic function, in that case, 2/3 of them did not get beta blockers, did not get ACE inhibitors or angiotensin receptor blockers, and most did not get referred for cardiology consultation.
So I guess, Ron, one could argue that in these patients with very severe cancer who are receiving chemotherapy, that a little bit of left ventricular dysfunction is the least of their worries.
So I think that's a good point and really gets into what I would see as the problem in this area. Most cancer therapeutics first get started in clinical trials in patients with widely metastatic cancer who are almost certainly going to die of their malignancy. In that case, just as you said, if they have a little bit of asymptomatic ventricular dysfunction, who cares? However, what happens inevitably over time is that the indications expand to the adjuvant or neoadjuvant setting in patients who might live decades. Very curable malignancies such as breast cancer or lymphoma. And now it suddenly is important, those significant drops in left ventricular systolic function.
Well, do we know what happens to those patients? Are we sure that if they show a reduction in ejection fraction from 55 to 45% that they'll ultimately go on to heart failure?
So we have very good data from the survivors of childhood malignancies. So these are mainly patients who got treated with anthracyclines for leukemias. And what we find is that a great number of them do go on to develop significant symptomatic heart failure. In fact, about 1/3 of patients who get treated for childhood leukemia, if you go out to more than 15 years of follow-up, have developed symptomatic heart failure.
So it really would be important then to get these patients either on ACE, ARBs, or beta blockers, or get them to a cardiologist. An important point, I hope our oncology colleagues are sure to read JACC and pick this up. Thanks very much for being with us.